Hello and welcome to our March edition of the A-CBT blog and author spotlight series. The aim of this series is to showcase the work of our diplomates and fellows from around the world who represent the highest standards of the Academy of Cognitive and Behavioral Therapies. And our hope is to show everybody what real CBT looks like in practice. And so this series is for both clients and clinicians to see CBT in action. So with me here today is Melissa Harrison. Melissa is the co-founder of the Center for Hope and Health and a licensed professional counselor specializing in evidence-based treatment for eating disorders, OCD, PTSD, phobias, and other anxiety disorders. She's a diplomate and certified trainer consultant with the Academy of Cognitive and Behavioral Therapies and a certified prolonged exposure therapist and supervisor through the University of Pennsylvania. She's also an adjunct faculty member at Temple University, and she co-authored the book called Comorbid Eating Disorders and Obsessive-Compulsive Disorder, A Clinician's Guide to Challenges in Treatment, published by Cambridge University Press. So, Melissa, let's talk.
Hi, so happy to be here.
It's so nice to have you. So the title of your article is Assessing AI Use in CBT, a Modern Daily Ritual. So the first question I have to ask is, what made you first start thinking about AI use as a potential reassurance-seeking behavior in CBT clients?
So I've been really fascinated with AI as it has come out, and it's just been so fascinating and revolutionary for people, checking it out and seeing what it does. So I had been personally interested. And then I actually had a client who was using it wasn't your traditional AI like open source or ChatGPT or something or Claude, but she was using a magic 8 ball generator, I think,
Oh,
to make decisions, and I'll talk about that case a little bit later. And so that was primed in my mind, and that we were sort of discussing that in ritual prevention and her ERP. And then when I became a parent, it's very typical, I think, for parents and all sorts of people to Google information, right? We were already doing a lot of Googling, I think, in
yeah.
our society. And I realized when I had my baby and I wanted information and I wanted it fast, I was like, wait, let me go over to some of my AI apps that I have. And instead of Googling, I didn't have to read any articles. I was just getting that information so fast. And that led me down a little bit of a rabbit hole of seeking information after having a baby that started to become maybe myself a little obsessive. And so through some of my previous experiences with Googling and sort of some of these other interesting things like a magic 8 ball generator, and then my own experience, I was thinking, I bet you her and I are not the only two people on the planet doing this. And so I started using it in some of my assessments and asking clients. And long and behold, people were doing it more than I had even known because I wasn't
Yeah.
asking. So that's sort of how that got started for me.
Yeah. Yeah. I think, it's so interesting. I think those of us who have like spent any deal of time in academia sort of been hammered into us that we have to be very, very careful, right,
Mhm.
about using Google and ideas and, things like that, copyright, whatnot. And so I think that some of us clinicians were actually pretty late to the game, right, when it comes
Mhm.
to AI. And a lot
Mhm.
of our clients maybe were there
Yeah,
faster.
right.
So in your article, you describe AI as a modern ritual. What similarities do you see between AI reassurance seeking and traditional compulsions or safety behaviors?
Yeah, so the first thing that comes to my mind is reassurance seeking, for example, and reassurance seeking when you're feeling anxious and distressed about a decision or what you look like or um, fear of an outcome, you sometimes will reach to a loved one, a family member, or a partner, and ask them their opinion on that. And then that sort of lowers that anxiety a little bit in the interim. And then, of course, that anxiety does not get fixed and it comes back sometimes tenfold later.
Right.
So, traditionally, anybody who works in OCD, for example, is very familiar with especially someone who works with folks who have health anxiety, for example. There's plenty of Googling, getting on WebMD, and do I have a brain tumor? That's been sort of ages, right? As clinicians, we've been dealing with that, and patients have been using those as resources. But what I found to be really fascinating about AI is it responds to you like a human. So when you're Googling, you have to Google the right thing. You have to find the WebMD. Then you're sort of reading an article. Then you're trying to read about brain cancer. First of all, there's a lot of steps, which is sometimes nice because when a client is in session and they're learning about this, there's a couple steps where they can pull themselves out of it.
Right.
There's a couple hurdles they got to get to really know if their
That's
migraine is a brain tumor. So that's one. It's harder to get the information. And there's not this like interpersonal experience that you have when you ask your mom or your dad about, like, do you think I have a brain tumor or something? And what's so fascinating is that these the generative AI models are sort of pseudo acting like a person.
Yeah.
And so you have this quick information of the internet. You have this almost this interpersonal relationship that sometimes people build with these generative AI.
Mm-hmm.
And then the AI doesn't ever tell you, hey, I'm getting bored of your questions, or like, you're annoying me.
Never.
Or like, honey, I don't know if you should be asking all these things. So there's so many guardrails that have gone out the window with this type of reassurance seeking, the Googling, the information seeking.
It's so true. It's so true. And it's so fascinating. It'll be like, no, Katie, that's not a stupid question, right? That's a very intelligent, and that's an excellent point. And you're really thinking in the right way here, right?
Right. Not only is this like an interpersonal response, but there's a lot of reinforcement. I think you're kind of highlighting. I think there's some really interesting and sort of funny TikToks and Instagram reels of making fun of like ChatGPT of how they respond. There's sort of like this example where someone pretends to rob a bank, and the AI responds of like, hey, you just robbed a bank. Just breathe. Like, where there's this really like warm and supportive response about this like horrible, stressful, illegal thing. And I think these models are trained to be sort of these warm emotional responses. And so yes, you can obviously identify impairment from sitting on AI all day and asking questions. You might have impairment occupationally. You might miss out on things with your relationship. But unlike when you're asking your mom 100 questions in one day, there's not going to be that organic, that organic impairment and dysfunction in that relationship. So that really worries me.
Right. Yeah. Oh my gosh, such great examples there for sure. So tell me, so how do clinicians and clients differentiate or distinguish between just healthy information seeking, right? Like, oh, I just had a baby. I want to get information about croup or, whatever it is. How do we distinguish those healthy information seeking versus compulsive reassurance seeking?
Mm-hmm. Yeah, it's a great question. And I have clients asking me that for all of their sort of like, rituals and compulsions of, it gets tricky, especially in OCD, but even in things like eating disorders. I would say the two things that I think about the most are, did it make you feel better? Because usually reassurance seeking and, rituals and compulsions, they do sometimes drop that anxiety and make you feel better right away. But did that piece of information bring down your anxiety, and did your anxiety pop back up later? Because so for example, I had a client who had OCD, and she was a young client, and she thought she could contract a UTI from a toilet seat, amongst other things. And we did some bank of knowledge, which, we kind of looked at the facts and just kind of got educated before we started ERP. And she had a number of other compulsions and assumptions about the world, but that actually went down with some psychoeducation. So she just like learned like that's not really how you get a urinary tract infection. And that one never popped back up, where there were other things that were, no matter how many times I told her it's quite unlikely to get HIV from a toilet seat, that one for some reason was just coming up over and over again for her no matter what, right? So I think when you get that bank of knowledge information, if that sort of satisfies you and you're not feeling the urge to go back and check, and you're not having obsessions throughout the next week, then that information that you kind of learned sort of landed in the brain that's not part of OCD. So that's one,
Right.
really big telltale sign, is that it's not popping back up so frequently. Another thing is typically when it's not obsessive compulsive or anxiety driven, you're not feeling the need to go back and reread it, or keep a post-it on your computer so you can kind of read it whenever you want. You're not revisiting it. You're not asking it the same question in 10 different ways. It's sort of like a one and done thing, because
Yeah.
even when you feel better about the information, even if your anxiety doesn't spike, you kind of want access to it. You kind of want to reread it. And so those are things that I would be keeping an eye out.
Right. That like, I want to make sure I didn't miss something. Let me just read it
Correct. Or
again.
like, let me
Right.
rewrite it a little bit. I feel good, but let me rewrite that one more time.
That
Something like
prompt
that.
just to see if I get a slightly different answer, right? And it's
Yes.
like
Yeah.
with health anxiety, this is also, right? It's one of the ways that we sort of determine what is sort of a normal, because we have to, if we feel sick, we really should go see our doctor, right? And so we have to go visit the doctor. But the question is, when you go to the doctor and they say, you're okay, can you walk away and be like, oh, phew? Or
Mm-hmm.
is that just a temporary few? And then you find yourself the next day, finding a new doctor or a whole bunch
Mm-hmm.
of new doctors to ask the
Mm-hmm.
same question to,
Right.
right? Yeah,
Right.
because it's
So yeah,
insufficient.
same thing with the AI, right? Do I go from ChatGPT to Claude? Do I suggest the prompt? It's sort of the same parallel to
It's
something
true.
different.
It's
Mm-hmm.
true. It's true. So, what kinds of clients or diagnoses do you think are most vulnerable to falling into this AI reassurance loop?
Yeah, I mean, the number one would be the folks with OCD, and OCD is sort of adjacent. So, health anxiety and straightforward OCD. And then, there's other disorders um that have something in common with OCD, which would be features like an intolerance to uncertainty, for example. So if
Hmm.
you're just somebody like, maybe you might have some generalized anxiety or some social phobia stuff, and you haven't been diagnosed with OCD, but you know about yourself that you don't like tolerating uncertainty. You're someone that might be vulnerable to going and getting that information all the time. Another group that's a little bit less clinical, is that if you're going through something vulnerable, like maybe you don't have OCD, but you just got diagnosed with something, some sort of chronic health diagnosis, or like me, like I wrote in the article, I had my first baby.
Right.
That is such a vulnerable time, with chronic health conditions or being postpartum. You're getting tons of information. My Instagram is targeting me. It's hard to navigate what's evidence-based. It's just, you're getting so much information, and the stakes feel high, right? Having a newborn, your stakes feel high. You don't want anything to happen to that little baby, or, you just got diagnosed with cancer and you want to survive. So when you're finding
Right.
yourself vulnerable, especially vulnerable to the uncertain, I
Hmm.
would say you want to maybe, like, watch out for some of these behaviors, diagnostically, OCD and health anxiety, but also social phobia, eating disorders. I would say up until AI came out, one of the things I used to warn parents of is my Fitness Pal, which many people may know is, an app that people use in their fitness journeys, and it can be used appropriately. But that was the app that many of my clients started counting their calories on.
Right.
It's sort of cumbersome. You got to open it up, you got to put it in, you got to pick which picture of the meal kind of looks like yours. It might not be 100% accurate. Now you can open up ChatGPT right in your whole meal, and it calculates all the macros in seconds. I mean, it's
Yeah. It's
unbelievable. So,
incredible.
I mean, that's another thing that maybe we don't look at as like reassurance seeking, but it sort of can be like, can I eat this? How
Right.
how many calories are in this? I mean,
Right.
people are some of my clients are talking to the AI all day long with
Yeah.
logging their food. So, um, those are sort of the diagnostics and also clinical features and like life situations that I would watch out for.
Right. Absolutely. It's so funny because I remember, I've had clients that it's like they see that TikTok video, right? And we have to remember too, it's not just AI. There are
Mm-hmm.
these algorithms out there that are targeting us for information that
Mm-hmm.
also kind of have a tendency to feed into this cycle. And so even if we're not sort of purposely seeking out the
Totally.
information, it's coming to us. And so I was reflecting on the one, TikTok video where somebody's like, I have this very rare condition where I suddenly realized at 35 that I have a peanut allergy, right? Never had one before, but went into anaphylactic shock. That kind of a TikTok video for somebody who fears allergens, right? Just right through the roof.
Totally,
And then
totally.
they're avoiding peanuts
And
and
they might not have
honey and
searched, just to your
gluten.
point, they might not have searched that. Then they spent long time looking at that peanut allergy because it caused anxiety. And then the algorithm realized, oh, you like peanut allergies, and it
That's
totally,
right.
you like to
Exactly.
watch peanut allergy stories. And then that affects when we think about social cognitive psychology, like the word I think is your heuristics, your availability heuristic. So
Yeah.
humans have a bias, right? And we think there's a higher probability of things happening when we've seen it in the newspaper in the headlines. And then if TikTok is sort of saying everybody has a peanut allergy, that's totally affecting your ability to understand the probability of how probable it is that you would have one, right?
Exactly right. Exactly right. So it's so interesting, and it's really very insidious these days, right? And how
Totally.
often do we have the clients that are coming to us and they're like, I think I have this because I saw this video, right?
I
I saw
know.
this video that talked about X.
I
So,
know.
okay, so for the clients who come to us and they're already relying heavily on AI to analyze social situations, like, we're going out of the house, I've had clients that they're taking a picture of the outfit that they're wearing to get feedback on how they look, thank God
Mm-hmm.
my hair looks fantastic today, but
Mm-hmm.
that kind of
Mm-hmm.
stuff.
Mm-hmm.
Or, they're analyzing social situations with AI or decision making with AI, like should I go on another date with this person,
Yeah.
right?
Yeah.
What kinds of exposures are helpful?
Yeah. Well, I think the first thing I almost want to jump in and say before I answer your question is for both clinicians and consumers of sort of running the costs and benefits of that behavior, right?
Hmm.
Because I think, and all good clinicians know to do this, but I guess I don't want to underestimate the emotional dependence that people end up feeling about these things, and they don't want to do it. They don't want to give it up,
Right.
because there can be like sort of a strange emotional interpersonal relationship with it in the way that I have never seen in Google. And you can see, I mean, these are far and few between, but there's certainly stories in the New York Times about people having sort of feeling like they're in romantic relationships with these. So there is
Yep.
something that's susceptible here. So I think that that's a point we all have to consider. But just like any kind of pretty manualized ERP, getting reducing and of course getting rid of the diagnosis of OCD requires both exposures and ritual prevention. And so I would be viewing that actually as a ritual on a daily
Yeah.
basis, right? So,
Yeah.
if your client is washing their hands, or recently I had a client who was putting toilet paper down on her own toilet bowl in her home that she pretty much lived with by herself, like doing that every day. Like we're gonna remove as much as we can, right, from the jump. And so
Right.
engaging in the AI would be considered a ritual in that kind of sense, and we have to stop as much as we possibly can. And
Right.
then maybe we would be moving towards some exposures, which could be, hey, ask them a question like this so we can get a certain answer, and then
Yeah.
we're going to do the opposite of what AI says to do
Right. Right. Oh,
and
I
tolerate
love
that
that one.
uncertainty. Yeah. So you might have a client who is asking the AI, give me 10 prompts that I can say to sound interesting before I walk into a room of my peers because they're having a belief that they're not interesting and they're awkward and they never have anything to say. And, you know, maybe that could be helpful for certain people, right? I don't think that that's pathology in itself, but if you have a diagnosis of social anxiety disorder and you are having an intolerance to sometimes looking awkward or that you have nothing to say, it's actually really good exposure to go into a situation like that and have nothing to say and seeing what happens, right? And so
That's
we
right.
really want to be explicit with our clients of like, that can be a tool for the future or that can be a tool for other people. But in order for it to get over what you got, we have to learn to tolerate awkwardness or the potential of. And maybe you're not the most interesting person in the room and like that has to be okay. So that would be some clinical examples of how I would bring it in.
Yeah. And it's so funny because I was just remembering that my husband got tired of looking at pillows that I was trying to choose for my couch in my office, right?
Yeah.
And so I said, I'm just going to ask ChatGPT, right? And so I
Mhm.
put pictures into ChatGPT and it hated, like, I mean, not hated, but it was like, well, they're very nice, but they're really not professional, et cetera, et cetera. So I bought those pillows. They're on my
Anyway, you
couch
did
right
it
now.
anyway.
I did it anyway. And do you know what's so funny? Afterwards, I took a picture of the couch. I put it into ChatGPT. I said, well, what do you think? I chose these pillows. And it's like, wow, that actually looks very professional and blah, 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 blah. So it's
Yeah.
really interesting the way that it agrees with us.
Yes, yes. And I think you had brought this up about appearance. It's so interesting. I heard a stat. I can't tell you the validity of the stat. I heard this a long time ago, but that like 10,000 people a month will Google, "Am I ugly?" And that was something
Oh,
I had heard years and years ago when I first started working with eating disorders and doing advocacy and prevention. And now I'm like, oh my God, these people can just upload their faces and have a conversation
yeah,
about what they look like. And one clinical aspect of eating disorders for some people is they have an intolerance to not knowing how other people perceive them at all times. And
right.
sometimes we just have to not know. We don't know what people think about us all the time. And we have this false sense of security if AI says, oh, I think this about you, but we don't. AI is not representing the larger population in any way, shape, or form. So, there's a lot of diagnoses where this can kind of come up in treatment. And I think I don't know if you feel like this as someone who works with OCD, but the more I work with OCD, the more I can get inside an OCD person's brain and the more questions I can ask about mental rituals, or
Yep,
I can sort of predict what they're maybe going to do so I can kind of prevent that. I think we have to kind of get ingrained a little bit about what AI can do so we can ask those
right.
same mental ritual
So
type questions,
true.
you know?
Yeah, I mean, body dysmorphic disorder,
Yeah.
right? I mean, that's
Yeah.
one that it comes up a lot. And
Yeah.
I have clients that really feel like because they have been working with AI on modifying their appearance, right? Like my nose needs to be just like this, my chin needs to be just like
Yeah.
this, my forehead needs to be just like this. They feel like they have it dialed in exactly how they should look,
Mm-hmm.
and so then and I've had clients that many, many surgeries later, and
Mm-hmm.
they're like, I hate this doctor. I brought them this picture that I created, and they didn't make me look like this. But it's like, this is in their mind's eye. This is something that's being artificially generated. And here you are, a real whole person, right?
Really
Yeah.
difficult situation for
And
sure.
very painful, very, very painful. And so I
Mm-hmm.
think, yeah, I think the caution is warranted. And I'm so happy you wrote this article. So Um, oh, we kind of talked about this, but what happens if somebody comes to you and they say, I really don't think I can trust my own judgment.
Mm-hmm.
And I have to ask
Mm-hmm.
AI.
Yeah, I mean, two things come to my mind as a CBT therapist. One is, how detrimental would that be if you lost your phone for a day and you couldn't ask them questions like what would the cost be there? So
That's
I would
right.
sort of had that motivational interview and conversation. And the second thing that comes to my mind um is to do a behavioral experiment on that. Like, okay, well, what like a little bit different, like a little tweaking, a little bit different than exposure, more so like, okay, you can't trust yourself. What do you think would happen? Let's operationally define that. Let's go a couple hours, 5 minutes, one day, whatever they're sort of willing to do, wherever we are in treatment. And let's see if that worst thing happened and let's see if you're able to cope with it. And as many clinicians know, sometimes the worst case sometimes does happen to us, but then our client copes with it. And that is so powerful too, because if we're talking about incompetence, being able to fumble and then picking yourself back up, there's so much rich clinical like dialogue there,
That's true.
obviously. So
Yeah,
yeah, I would be framing that as a behavioral experiment. um and also a lot of those clients who say that, those people tend to also have self-worth and self-esteem issues, and they're also coming to me for that. And I say, listen, if you want to build yourself up, relying on this robot is incongruent with that goal of self-worth. So we
that's
have to start
true.
acting like someone who trusts themselves, and what does that look like? So those are sort
Yes.
of the two or three things I would think about there.
Yeah, and just for everybody who's watching right now, what you just heard was what a wonderful CBT therapist sounds like, right? Directive, really giving substantive responses, we are not head nodders, right? We
Yeah,
just
that's right.
aren't, right?
That's right.
All right. So, oh, I did want to, it's interesting. Some of the stuff you were saying, it sort of made me think back to the what you talked about in terms of functional analysis. How
Mhm.
might functional analysis help clinicians conceptualize AI reassurance seeking? We sort of talked about this, but I thought maybe it might be good for you to describe functional analysis and for us to talk about the role that that might have in assessing AI use.
Sure. So I think all good CBT therapists were maybe interested, but not always focused on the why and the childhood always. Of course, that's helpful for conceptualization, but that's not always the focus. What we are really concerned about is what's maintaining the problem. And so a functional analysis is sort of a way to sort of probe and prod and to ask questions about, what happens right before, what happens right after. What do you think this is doing for you? How do you think this is maintaining the problem? Because that's really asking a series of questions of typically using a situation. What are you thinking about? What did you do after? What was your behavior? Asking a
Right.
series of questions, collecting data is
Mm-hmm.
really going to help us narrow in on what is maintaining the problem, which is essentially what our treatment plan is. Like
Right.
how do we strategize to kind of connect into that problem? And so
Mm-hmm.
you're someone who's like we were just talking about, Katie, like if I have low self-worth and I don't, I have low self-worth, I don't think I'm competent, I don't think I'm capable, and then I find out you're asking AI what time should I eat lunch and when should I go to the bathroom? I'm like that. Okay, well, that seems like that might be maintaining the problem that you don't
That's
trust
right.
yourself. You don't feel like a competent person. And so
Right.
motivating that client to remove that behavior might really assist that person to feeling better about themselves and that they can live on their own.
Right. More confident, more
Mm-hmm.
competent.
Mm-hmm.
Exactly.
Mm-hmm.
So you and I had talked just briefly before we started this interview about your book, and I wanted to make sure we discussed that because so your book is about this idea of comorbid eating disorders and OCD and the challenges that that presents in treatment. And you and I were talking about how commonly these two things do present themselves in our clinical practice, being people that treat OCD. Do you want to talk a little bit about your book?
Sure, sure. So, like you said, there are some studies that say, from 15 all the way up to 60%, there could be an overlap. Those numbers are wide, but at the end of the day, my business partner, Dr. Delassie, and I were both seeing this so often in our practice that we felt like we had to really put our heads together and think about this because there are evidence-based manuals, obviously, for OCD and also eating disorders, but there really wasn't much on a manual of what to do when you have both. And
Hmm.
unlike maybe some other disorders, even though these two disorders are very similar, they sometimes coincide in a way that one clinical intervention may be contraindicated for the other presentation and vice versa. And so it gets really tricky. So, one example that we talk about in the book is that when you're following CBT Enhanced for Eating Disorders, which is an evidence
Hmm.
based manual for um, adult anorexia, but also bulimia and binge eating disorder. Um, One of the things that it calls for is collaborative weighing, which serves as sort of like an exposure, a way to get a moment for psychoeducation, um, a way to challenge a belief system, like in
What's
OCD.
collaborative weighing? Tell me what that is.
Oh, sure. So, in the beginning of the session, sort of after pleasantries, you have the client collaboratively get on the scale, which means they're consenting to it. We've sort of talked about this plan before. We see the number and we kind of use their food records or their belief systems to challenge. So, for example, maybe someone thinks that if they have one dessert throughout the week, they'll gain 5 pounds. And although there's nothing bad inherently about gaining 5 pounds, some people need to gain 5 pounds, it's just a mismatch with reality in the same way
Right.
of OCD. Like, you sometimes will get a cold from touching doorknobs, but it's not immediate that I'm going to get a cold just because I touched one doorknob, right?
Right.
And
Right.
you use the scale as sort of exposure for increasing education and fixing that broken cognition.
Right.
Um, what's really fascinating about the folks who get on the scale, well, a couple things, but one that I'll give an example for, as the client gets better, so let's say you're working with someone with anorexia and they are required to gain weight as part of their treatment plan and to get better. and they get into a really nice weight category and they're feeling better and their cognitions are clearer and their mood is better and they're feeling more confident and they're entering recovery. If they have a pre-existing condition of OCD, and we know with OCD, it latches onto the things that we care about or we're passionate about or that we're vulnerable for.
Yeah.
Someone who just worked really hard in their recovery, that may become their obsession. And
Right.
what ends up happening is they start obsessively wanting to get weighed and they want to make sure their weight hasn't gone down because they're so afraid of relapsing. And so
Right.
the OCD kind of globs onto relapsing, and it would be clinically indicated actually not to weigh those folks at that
That's
time. We're
right. That's right.
sitting with the uncertainty that maybe you are relapsing, which is a very complicated thing to do with someone who needs to gain weight and needs to maintain their weight. And so we sort of talk about some really challenging scenarios when you're kind of with these two really strong diagnostic profiles.
Yeah. And we're gonna include a link to your book so that people can purchase it, people that are interested,
Mm-hmm.
because I mean, it really does fill a gap in clinical
Mm-hmm.
practice, this book
Mm-hmm.
you wrote. And so good for you. That's so
Thank you.
wonderful.
Thank you so much.
So we do have to finish up because I
Mm-hmm.
have to let you go, but I just want to say thank you so much. And you're just the perfect example of why it is that we do this, because people out there need to hear what difference it makes when you see somebody who's a real CBT therapist, right? And it really does make a difference. And certification matters. Contrary to what some people might say, certification really does matter. There's a lot of people out there who say, well, as long as I'm seeing a licensed therapist, doesn't that mean that they were well trained at CBT? And that's actually not the case, unfortunately.
Yeah, especially
Unfortunately.
for these disorders that are really, life threatening, and
Yes.
have a high suicide rate, or, with eating disorders, there's health complications that you really want to see someone to get you better as quickly as possible, right? Because your life and your
Right.
time is important.
That's exactly right. That's exactly
Mhm.
right. So I hope that this information helps clients out there that are looking for a therapist become a little more educated about what they're looking for. And, to clinicians who might be sitting there thinking, oh, do I need to get more training in CBT and
Mhm.
watching this? I hope that this
Mhm.
helps them make that decision to take the plunge to get further training in
Yeah.
CBT. So it was just wonderful meeting with you today. And just as a reminder to everybody watching, if you're an A-CBT diplomate or a certified clinician interested in being featured in a future blog and author spotlight, I'd love to hear from you. And so please reach out to me. And Melissa, thank you so much. It was just wonderful today.
Thank you, Katie. I really enjoyed it. Thank you so much.
Thanks. Take care.
Bye.